So you'll be glad to know I'm not going to stand here and talk about commissioning for half an hour, because after lunch that might just do us all in, me included. I've interpreted the brief quite broadly, because I think what we're trying to do at the moment is build a new way of us looking at our children's health and well-being across Lancashire and South Cumbria. So that's where I'm going to interpret it. I do get to some commissioning bits at the end, and I'm then really happy to take questions. I know there were a few questions about commissioning at the end of this morning's session. So we are doing a piece of work looking at how we commission services at the moment for Lancashire and South Cumbria. And I will, as I say, I'll get to that at the end, but if you'll just bear with me, I want to explain why we're doing it, because it's really easy for us, including those commissioners in the room, to kind of get lost in the process of what we're doing and forget why we're doing it. So, we want to do things differently, and I'm going to explain why, what the rationale is for us doing things differently. The case for change for that comes from the 5-year forward view, so I'll talk a bit about that. We have adopted a place-based approach across our ICS, and I'll explain what we mean by that. I'm going to talk about a few first steps that we're wanting to take, and then I'm going to come on to how we're changing the way that we commission services. So why do we want to do things differently? None of you need reminding about who our children and young people are and why we need to do things differently. When I show these slides to some other audiences, they do need reminding. So when we talk to the Health and Wellbeing Board or to the Integrated System Board, they need reminding sometimes that actually 25% of our population is young people, and we don't necessarily spend 25% of our money on children and young people, and we don't spend 25% of our time trying to improve things for children and young people. So I'm not going to run through all of those, because I think you know all of those. There are some things that we could really do differently. So I don't know if you can read these from the back. I'm sorry if some of the text's a bit small. The estimated cost of smoking in Cumbria and Lancashire is between $227,000 and $1.8 million per year, depending on how broadly you do your costings. Wider societal costs associated with preterm birth are around 4 to 6.4 million. In the first 5 years of life, each birth to a teenage parent costs £57,000, i.e. 20 million a year over Cumbria and Lancashire. So there's some really big figures in there. Around, and the next one as well, around targeted parenting programmes, we can recoup ×8 the amount of money we invest in targeted parenting programmes. So really big things that we could do differently, and I think we all in our own working lives, whatever role we've got, can see that there are things we could do differently if only we could spend the money differently. So our aim is, and I think I hope I'm speaking for everyone in this room, to improve the health of our children and young people and for them to grow up to be a healthier generation of adults. And what we're trying to do is to get that aim really embedded across the integrated system, so that that is a shared aim, because actually if our whole integrated system could have that aim of improving the health of our children and young people, they would resolve a lot of the funding difficulties that they've got across the wider system for adults in the future, wouldn't they? We know that, but we're trying to make sure everybody remembers that. So by doing this, we'll reduce the increasing demand on our whole health and social care system across Lancashire and South Cumbria and make it more sustainable for the future. So we're not just fiddling about with commissioning for the sake of it, we're trying to achieve those things. And I should say, actually, Dr. Arif Rajpura, who was here this morning but has had to leave, is our children's champion across the ICS, and he's leading this piece of work. So I'm kind of standing here on behalf of him, really. So let's remind ourselves about what the 5-year forward view said about what we're trying to achieve and why we are now, as a whole healthcare system, moving towards doing things on a Lancashire and South Cumbria basis and working locally as well in neighbourhoods. So the 5-year forward view said that there are 3 main things we need to address. We need to sort out the health and wellbeing gap, and that means getting really serious about prevention, not just rhetoric, not just talking about it as we've done for years, really doing things about prevention. We need to address the care and quality gap, and what they mean by that is getting rid of the variations in the quality of care across the board. So we know we've got a number of key pieces of work, particularly our neurodevelopmental pathway work going on, that's about getting rid of variations across our system where they're not warranted. If they're warranted because the population needs are different, then that's a different thing. But unwarranted variations we need to resolve. So reshaping care delivery, harnessing opportunities from technology, all of that. And then the third one is the funding and efficiency gap. So we need to match reasonable funding levels with wide-ranging service efficiencies. So that's about making sure we do everything as efficiently as we can and that we have the funding available to do that. But we can only do that, we can only release the funding to do the things we want to do by doing things differently. So these slides will come out, and I probably shouldn't read this through, but when I was putting the slides together, I really felt like reading this whole next 2 slides to you. So I might judge how boring I'm going to be. So if you start nodding off, I'll notice. So the 5-year forward view, these are direct quotes from that 5-year forward view. It says a better future is possible, and with the right changes, the right partnerships and the right investments, we know how to get there. There is broad consensus on what the future needs to be. It's a future that empowers patients to take much more control over their own care and treatment. It's a future that dissolves the classic divide between family doctors and hospitals, between physical and mental health, between health and social care, and between prevention and treatment. It's one that no longer sees expertise locked into often outdated buildings with services that are fragmented, patients having to visit multiple professionals for multiple appointments. Does any of this sound familiar? Endlessly repeating their details because the systems use separate records. One organised to support people with multiple health conditions, not just single diseases. And a future that sees far more care delivered locally, but with some services in specialist centres where that clearly produces better results. And finally, one that recognises that we cannot deliver the necessary change without investing in our current and future workforce. I couldn't find any better words to put that in, because I think that says it all. That says what we're trying to achieve and why we're trying to achieve it. So what does that mean for those of us who are involved in commissioning and providing care for children and young people across Lancashire and South Cumbria? So we need to create a new focus on improving health. That's really clear. And as I said, we've got Dr. Rajpura is taking a lead on that as a children's champion across the ICS. And his remit is to delve into every single work stream across the ICS and shake them up a bit and say, what are you doing for children? We need to resolve the fragmentation in our system. So that's about us integrating things, integrating health and social care, doing things, as Salman was talking about earlier, where GPs and hospitals are working more closely together, sharing education, sharing ways of working. We need to find ways of doing things differently, and we talk a lot about some of the digital solutions that there are around. We need to overcome variations in quality and access, and we need to design and provide care as locally as possible. So that's the bit, I think, if I remember rightly, what my next slide is, that I'm going to go on to talk about, because we are moving from a system where we have 8 different CCGs commissioning each individual health system separately to doing things more collectively together where it's sensible to do that. So this is the place-based approach. Oh, that map hasn't come out. Sorry, you'll be able to see it better on the slide, but it's a map of Lancashire and South Cumbria, so you can imagine it. So across Lancashire and South Cumbria, we are now working as an integrated care system, and we have a board set up as an integrated care system board, and various things are starting to happen now on that whole footprint. We're working together on a number of pieces of work, and this is one of those. This is a key one of those. That system is made up then of 5 integrated care partnerships, which are shown in a rather blocky way on this map. So that's where NHS and local authorities are formally working together to improve health and care. And some of this, so those of us who know about Devo Manx, where they're working together, they're doing it in a very formalised way now between health and local authority with a devolved budget to do that. We've not gone that far yet, but that's the direction that we're heading in, really genuinely working together across health and local authorities. It's really challenging to achieve, but that's where we're headed. And then at a neighbourhood level, and we've got, I think it's 41 neighbourhoods across Lancashire and South Cumbria. We've got geographical areas where GP practices and other health and care services are working together to ensure joined up care tailored to the needs of their local populations, and with some authority around how they do things, so giving them the accountability to define how things happen on their patch for their population, and making sure, for instance, that our GP practices know who their schools are in their area and are working closely with their schools. And where that happens, it's brilliant. You really see some very practical changes beginning to happen about, well, actually, couldn't we deliver a clinic in school? What about how do we support teachers in school who have health conditions? Well, maybe they can just go to their local practice. They don't have to go home to where they live. All sorts of very local things happening where we've got our neighbourhoods joined up with the local health providers and other providers in their area. So those are for populations of typically between 30 and 50,000, but it varies enormously. There's some a lot bigger than that and some smaller than that. It has to make sense to the local community what size their community is. So some first steps in helping us to work in this way. We are planning to set up a strategic board for children, young people and maternity, which will bring together system leaders to drive change. And our integrated system board is approving that we can work in this way. And we're just looking to get some capacity to start setting that up. There are a number of key work streams already established and making real progress. This is one of them. Those of you who were at the Maternity Assembly last week or a couple of weeks ago, that's another one. The work that we're doing on the neurodevelopmental pathways is another one. So there's a number of really key things happening now that are being led at an ICS level. And there's also lots and lots of work going on within individual integrated care partnerships, so in the 5 local areas. Salman's told you about some of the work we've been doing in Morecambe Bay, but there's lots of other pieces of work going on as well to help us work in this more integrated way. And then at a neighbourhood level, there's even more things going on. So I'm aware within our CCG area, there's lots of pieces of work going on that individual neighbourhoods are working on around children and families. There is a tendency, I think, for those neighbourhoods to be focusing at the moment on issues around older adults and frailty, and we sometimes struggle to get them interested in children and young people. They're often very interested around emotional health and wellbeing because they really see the impact of that within their schools and within general practices, and they see all the admissions that they get and all of those sorts of problems. So we have ways in, but we need to get them more and more interested in our children and young people and how they can work with us. And in order to do all of that, we need to change the way we're commissioning. So I am finally getting to talk about commissioning a little bit. So what are we doing to change the way we commission services? So we want to do things once where things are sensibly commissioned once at a system level across Lancashire and South Cumbria. I think between us as commissioners, and there's a number of us in the room, we feel as if we often waste a lot of time because we're all trying to do the same things in our own local patches, and then we try and join up together and do it collectively, and then that means there's 5 or 6 of us in the room trying to agree on what we're going to do collectively. Well, we think we could do that better. We could just do it once. So we could, particularly things like setting standards and outcomes, we can just set once across the whole ICS. We can do performance measurement once across the whole ICS for quite a few things. What we really, really want to safeguard is those things that need to fit with other services at a more local level. So we don't want to end up commissioning things once at a whole integrated system level and losing that local flavour of what needs to happen within Morecambe Bay or within on the Fylde coast around what their population needs that might be different, the way other local services are happening that are different, third sector organisations that are different. So we really want to make sure we keep a way of linking into those local areas, and I'm not going to pretend we've found the answer for that yet, because we haven't. But also those services that need to be part of an integrated neighbourhood team. So for children and maternity services, quite a lot of the services we commission, we want to be part of the neighbourhood team sitting around the table with all the other partners in a local neighbourhood. So we need to be flexible enough about the way we commission them to enable them to do that. And we want to make sure that those local neighbourhood teams have enough opportunity to say, well, actually, we think there's a different way of us doing this. If you could give us this bit of resource, we could get on and use that differently. So, for example, around children's emotional health and wellbeing, if there was an individual neighbourhood who said, we want to work more upstream, we've got a plan to work with our schools, we're really confident it's going to make a difference, we've piloted something, but we need you to give us some of the resource that you commission at the moment and let us use it in a different way. So that's the last point about needing to be responsive to different needs at a neighbourhood level. So that's in summary is about 50 slides worth of what we're doing on the commissioning framework, but I didn't think you'd want to see all 50 slides. So just to take an example of that, so around maternity, for example. So maternity is one of the things that we think we could probably sensibly commission once at an ICS level to some degree. So we definitely could set standards and outcomes once. We have looked over the years at trying to have single service specifications for maternity services, and that would be great if we could work towards having a single specification across the whole ICS. We also know that our public health partners are responsible for some parts of the maternity pathways, so we could do that more collectively with them at an integrated system level. However, we still want to be able to make sure that we review that service delivery in terms of how it meets the needs for a local population, but that might be by having a commissioner or a couple of commissioners at an ICS level who make sure they link into a local ICP level. Or it could be that we have somebody in ICP level who's responsible for making sure that things all fit together and work together at that level, taking on board whatever's been commissioned in terms of maternity services at an ICS level. So it does get into quite a lot of detail when you look at the individual stages of the commissioning cycle, but what we're trying to do is to work through it on a service-by-service basis or in clusters of services where there's a similar rationale, so that we're really clear what kind of changes do we want to make and at what level in the system do we need to be able to influence those changes. So we have identified 3 commissioning priorities, which are the first things we want to work on in this new way. We want to work on improving the health and well-being of children and young people, increasing resilience and reducing inequalities. That's quite quick to say, but not quite as easy to do. So we've identified 6 priorities within that, and there is work starting to look at, from particularly bringing together our public health teams across the patch to work together on some of those. We want to ensure that we have sustainable delivery of fragile services. So we know that within our children's and young people's workforce and in our maternity workforce, there are parts of our workforce where we don't have enough professionals. We really struggle with recruitment. It's getting harder. It's not getting any easier. So we know we've got some really fragile services across our workforce, and that's a lot of the work on the acute work stream, the acute children's work stream, is getting into that level. But it does also include local authority services as well as NHS services. And the third priority is about embedding trauma-informed approaches across health education and social care. And it might be, where's Vanessa? I can't see Vanessa. That might be something that would maybe do at a future one. She's done it already. She's done it. But there's work going on now across the whole ICS on that. So that may be one we keep bringing back. So in conclusion, so we need to improve our children's health. I think we have a collective shared aim around that. And we need to create the very best health and care system for our children and families, which involves making the best use of our joint resources. We can only do that by working together and removing the unhelpful barriers that there are from a commissioning perspective, but also from a provider perspective, and empowering our children and communities and families to support their own health and also to work with us when we're involved in their care. That's it. Thank you. That's not a bad clap for the graveyard slot.
Questions for Julia?
Hi, I'm Ash, one of the community paediatricians who work across Kendal and Barrow.
Hi. Talk to you.
Yeah,
met.
I think the geography says South Cumbria every time, and CPFT is not there in the picture of contributing anything in the bigger scale. Better Care Together was mainly, again, led by Barrow team and Lancaster team, and we were only minor part of it. So I just wondered again, where are we heading from our local part of it from the Commissioner's point of view?
Okay, we can maybe have a more detailed conversation about that, because there's lots we could say about that. So in South Cumbria, CPFT obviously covers the whole of Cumbria. So we do have a bit of a challenge around some of our boundaries in South Cumbria. The County Council also covers the whole of Cumbria. So whereas all of the other authorities, actually West Lancs is another one, isn't it, where we have boundary issues. And it is tricky, but what we're trying to build is a clear integrated care system. And I was at the Health and Wellbeing Partnership in Cumbria this morning, which is why I was late getting here, saying we are now going to plan for our emotional health and wellbeing for children on a Lancashire and South Cumbria basis, because if we want to try and integrate, you have to draw a boundary, unfortunately. And it's got to be somewhere, and it's never going to work for all partners. But we have elected, the powers that be have decided that it's going to be Lancashire and South Cumbria, so that is the footprint that we're planning on now. And obviously within Morecambe Bay, CPFT is a really key partner for us, as is the County Council. All right.
Questions, yeah.
Hi, Julia. Sorry, I wanted to ask a couple of questions. The first one was around the 6 priorities. Is that information going to come out to us? Because I'd like to know what the 6 priorities are.
Yeah, sure.
Certainly from...
yeah, I'll send it out with the slides.
That'd be wonderful. Yeah. That'd be really good.
There's no surprises. It's things like smoking and pregnancy and dental. And
I thought it would be, but I just wanted to double check. And then you mentioned very quickly around targeted parenting programmes earlier on in your presentation. Is that something you're going to be talking to our public health colleagues around? Because as you know, we've had targeted parenting programmes before. The funding's been reduced for that, and we've had to decommission services. Yet we do know that they are very successful and have really good outcomes, particularly for teenage.
So that's one of the things that we've flagged, where there's real evidence that if we did things differently, there would be a real benefit. But we can't work on everything at the same time. So we've identified the 3 priorities that we're working on first. That doesn't mean the targeted parenting programmes won't come in there at some point in the future. But what we've got to do first of all is set up our system in this way, because at the moment we don't have any any resource to do this work at a Lancashire and South Cumbria level. So we're all individuals just putting in bits of our time to try and lead things at a Lancashire and South Cumbria level, but it means we've still got the day job that backs up back at base. So we need to create the efficiencies from a commissioning perspective by saying, well, look, I can do this once, Steve will do this once, Sarah will do that once for all of us, and thereby we free up some time to take forward other pieces of work. And we need our local authority partners to do the same.
Yeah, that's fair enough. Thank you.
I might ask a question while you're walking across. I was wondering, I mean, this morning I saw some really good models that can work really well, but it needs engagement. And if the engagement's not there, it's difficult. Now, then there's carrot and stick kind of ways of approaching that. Now, the ICS at the moment doesn't really have that power yet, I think. But actually, there could be pool with commissioning, and sometimes sequence can make a huge difference. Is this something that we're looking at as well?
Yeah. Yes, I think individual commissioners use sequins at the moment to make a difference, but those sequins have been agreed on a bigger footprint actually for a couple of years now, rather than as doing it individually as CCGs. You're right, at the moment we kind of don't have the teeth, because there hasn't been the legislative change to enable us to move to an integrated care system. So it is still the individual CCGs that hold the budgets and that have the accountability. But what we need to find is structures that enable us to work collectively whilst still having the budgets and accountability held by CCGs. But yeah, we need to look at every lever we can find, don't we? Yeah.
Difficult question for a clinician, I guess. Simple probably for you, I guess. You're not that you are a clinician as well, sorry, but in a different capacity.
No,
Working along projects, this question of money comes in and out, whenever it comes, my brain switches off. And then recently I'm hearing this, it's all one pot. It's now going to be all one pot.
Yeah.
Is this real, or is this just people saying it to make me feel better?
So if you look at the Devo Manx model, so in Manchester, they now talk about the Manchester pound, don't they? So the Manchester pound is about having put the health and local authority funding into one pot, and you can only spend that pound once, I suppose, and it doesn't matter whether it's health or local authority because it's all in one pot. We have ambitions to do the same across Lancashire and South Cumbria, but we're not there yet. But that is certainly the way that we're thinking. And within each individual, I suppose across the whole integrated care system, there is a recognition that we need to work much more jointly together and work towards efficiencies on both sides, I suppose, so that we do just have one pot of money and we use it as sensibly as possible. Definitely within local integrated care partnerships, so for us at the Morecambe Bay level, we do talk a lot about, we have a Morecambe Bay pound and we can only spend it once, and that is a health and local authority pound that we need to spend in the best way possible. It isn't a real pound yet, it's a virtual pound at the moment, but yes, that's the way that we're starting to work.
Mine's a kind of a question as a clinician, always struggle a bit with where people have the money and who's got the control on various bits. So I'm interested in the critical care and the HDU and that kind of side of it. So obviously at the moment, with where we are at the moment, we haven't got a big children's hospital within our patch, and that's where a lot of the retrieval teams and the big hospitals are. And with the De Novo Manchester, they seem to have some money that's going around with their HDUs. And I was just wondering, is there much discussion with other patches, other areas, with discussion with regards to commissioning for the HDU, and also being able to use, because obviously the retrieval teams and their intensive care teams are kind of out of our patch. Where do we fit in with that?
Yeah, so part of our plan to do commissioning differently is also to look at some of the things that are commissioned on our behalf by NHS England. at a more specialist commissioning level. So it's not only about the CCGs commissioning differently together and the local authorities, we're also wanting to work differently with NHS England. We're not very far along the road yet in terms of thinking exactly how that works. So in terms of specific discussions about transport teams, for example, we're not there, we're nowhere near being there yet, but there's definitely an ambition both from NHS England and from ourselves to work differently and to be more responsive to local need and the fact that we might want to do things differently locally. That's part of the answer. We had discussions only last week between the CCGs about HDU, and Vanessa came to talk to the CCGs to talk about the issue of HDU and funding of HDU. So we're very aware of that issue, and there's a piece of work going on, isn't there, with Commissioner involvement in that piece of work. I don't know if Steve wants to say any more on it at the moment.
Specific work stream looking at HDU, which is led by Vanessa Home here. And on that work stream, we do have specialised commissioners, local commissioners, NWAS, because of the transport issues and how they're going to become bigger in the future. So, and we are making some good progress on that work stream, actually, from last week, motoring ahead. So hopefully we're getting the message across.
I think in all of these, there are some really gritty, difficult issues in here, and we can't pretend that some of this is easy because it really, really isn't. But what I'm really confident about is that everybody is in it together, and we are now all saying we are in this together. We've only got the money that we've got, and we've got to make it work as well as we can between us. So I think everyone's up for looking at different ways of working. So we're all trying to work together to resolve some of those gritty issues like HDU.